I'm really happy to be with colleagues today and regard the community of pediatricians and related clinicians and public health experts in this area. It's a real privilege to be part of this community. So thank you very much for that introduction. I'd like to now load my slides. And I trust you can see that, colleagues. So let me start off, first of all, by saying thank you to Dr. John Babineau, who's the president of the Babies Hospitals Association, to Dr. Jordan Orange, the chairman of pediatrics, and to Dr. Prince, who is a professor of pediatrics in the Division of Infectious Diseases. Colleagues, let me just start off by acknowledging research assistance provided by Isabel Sophie Venturis, who works with me with the Vaccine Safety and Confidence Building Working Group at Columbia, to note that I have no conflicts to declare. So,
Dr. James, so sorry to interrupt. I think you just need to switch your screens right now. We're seeing the regular PowerPoint. Perfect. Thank you. Sorry.
Does that look fine?
We saw the title screen for a second, and now we see the regular PowerPoint again. That looks good.
Okay. With thanks. So to note that this lecture is delivered during the World Immunization Week of 2022, and that this event is celebrated annually during the last week of April. And this week, as will my lecture, underscore the collective action needed to promote the use of vaccines to protect people of all ages against disease. The WHO and UNICEF work with countries across the globe to raise awareness of the value of vaccines and immunization, and ensures that government obtains across the globe to raise awareness, and that governments obtain the necessary guidance and technical support to implement high quality immunization programs. The ultimate goal of World Immunization Week is for more people and their communities to be protected from vaccine preventable diseases. This lecture is a special tribute to UNICEF, an underfunded and overstretched United Nations agency, an entity that carries the responsibility of worrying about the world's children, and which doubles up, as you know, as a monopsony, which is a monopoly that delivers COVID-19 vaccines and other vaccines to the developing world. It is worth noting that historically an agency set up to care for Europe's children after the Second World War turns full circle to its original purpose, with a task 70 years later of bringing some comfort to traumatized children damaged by the war prosecuted by Russia against Ukraine. Yesterday, UNICEF and the WHO issued their perfect storm warning, which is that measles cases increased by 79% in the months of January and February of this year, and that conditions, and I quote, are ripe for serious outbreaks of vaccine preventable illnesses. There is, I must tell you, colleagues, very little good news here. The structure of the lecture I will give today is organized around an effort to answer 5 questions and to pose an imperative. And those 5 questions are: what do we know about COVID-19 and child health in Africa when it comes to pediatric infection rates and mortality? The impact that has had on routine immunization programs, the impact on child mental health, the impact on health worker availability, including in the domain of pediatrics, and the impact on health systems. And the imperative is what is then to be done. But first, I asked the question, what is Africa? It is a vast geography consisting of 55 countries and 2 disputed territories. It is oriented north to south with formidable and climate-related barriers. It has no navigable rivers that can be used for trade. It does not have a single national state. All the countries are multinational and multi-ethnic. My own country, South Africa, has, for example, 11 official languages. 11 African countries are listed as free under the Freedom House Index. And they are Botswana, Mauritius, the Cape Verde, Senegal, Tunisia, Ghana, Nigeria, Sao Tome and Principe, Namibia, South Africa, and Benin. These are the countries presently of the 55 that have one war or the other going on, some involving civil wars, others involving a combination of civil war and ethnic violence, and many are exposed to terrorist insurgencies on some of their borders. Africa has the largest number of countries who fall under the category of poor, and therefore has the largest assembly of the world's poorest countries. Africa is the only continent with an unbroken fossil record of modern human origins. In terms of fossils, it has the most ancient repertoires of hominid genomes. And finally, Africa is a continent consisting of very young people. This is an age-sex pyramid. It has a population of 1.4 billion people. Its population growth rate is 2.49% compared to the US of 0.9 and Europe of 0.4. It has the highest, as you can see, the proportion of young people within the population as a whole. 41% of Africa's population is under the age of 15. In the United States, it is 18%, and in Europe, 16%. It has 41.6 deaths per 1,000 live births. Europe is 3.2 per 1,000 live births, and its total fertility rate is 4.4 live births compared to the US's 1.7 and a 1.53. And if you add up all those demographic figures, what you see is an age-sex pyramid that is bottom-heavy with young people. This has major implications, and relevant to this talk today. It explains largely why the COVID-19 pandemic has had not as severe as an impact as we expected it to have. I want to make a point about moral philosophy to say that children have exactly the same right to health and life as adults, but because they are legal minors, they are not enabled to act in their own self-interest, and they rely on adults to do so on their behalf. And the question is, what kind of job have we done with that responsibility? There's a second related question to do with the global entity responsible for children, is why UNICEF is so undervalued and underfunded. And finally, why there are so few children's champions today. And I wanted to mention my own hero, Nelson Mandela, who his first act was to establish the Mandela Children's Fund. When he stepped down as president, he became a UNICEF ambassador. His annual birthday parties were always parties of children, thousands of children he would invite. And he once explained to an audience why he has this approach to looking after children's interests. In a hall assembled dinner one evening where For some reason or the other, a child was present at the dinner and cried, and the people wanted to remove the child. And he got up and said, "No, you will not do that. I want to point out to you that I spent 27 years in prison and I never once heard the sound of a child. And I want you to imagine what kind of poverty that creates in the soul." And the child stayed. So this is a picture taken with David Baltimore, who at the time was president of the California Institute of Technology, who gave the Nelson Mandela Science Lecture on the origin of HIV. And when we departed from this meeting, given South Africa's own history with HIV, and the fact that the president that followed Mandela listened to AIDS dissidents and tragically did not introduce antiretroviral drugs when they were available, costing an estimated 500,000 lives, Mandela turned to me and said, after listening to David's summary of where South Africa stood on HIV, he said, "If government does not do the right thing, take the fight to him. Take the fight to government." And so, and it's in that spirit that I want to talk to you today about the topic. So, colleagues, the first question that we need to deal with is to really just talk about what we know about pediatric COVID-19 infection and death rates. And to say, first of all, that when we look at the attack rates, it is flat across the age spectrum. So most of the seroprevalence surveys that have age disaggregated patterns generally show flat attack rates across age ranges, and there is little to no difference when it comes to the risk of SARS-CoV-2 infection by age. Well-publicized early studies suggested that under 5-year-olds and younger are innately less susceptible, but there is a question about whether the impact of school closures contaminated the results. But if there is any age-related attack rate effect, it is limited to under 5-year-olds. Secondly, studies indicate that of pediatric patients, males between the ages of 11 and 18 were the highest risk for contracting the virus. They also indicate that 83% of pediatric COVID-19 cases were acquired from household members. A Canadian study published in the CMAJ Open confirmed that SARS-CoV-2 spreads extensively in households, with children having a significant source of that spread, being the significant source of that spread. The researchers concluded people with SARS-CoV-2 infection transmitted extensively within their households, with a secondary attack rate of about 50%. Although children transmitted at a lower rate than adults, they still infected 1/3 of household members. The third point is that compared to adults, children are not as likely to face, as you know, severe health risks from COVID-19. The clinical presentations of COVID-19 in children are typically mild and asymptomatic. Recent studies suggest that innate immune responses of children help resolve a SARS-CoV-2 infection more rapidly than adults. There are, of course, as you know, reports of rare but serious multi-system inflammatory syndrome affecting children and adolescents. The clinical features include, but are not limited to, persistent fever, rash, red or pink eyes, swollen or red lips, tongue, hands, and feet, and gastrointestinal problems, low blood pressure, poor blood flow to organs, and other signs of inflammation. Children who have these symptoms typically seek medical care. Early diagnosis and treatment, as you know, are critical, but initial reports suggest most cases responded well to anti-inflammatory treatment. The case fatality rate globally is different comparing lower to middle income and higher income countries. A meta-analysis of fatality rates in lower and middle income countries, and these, I make this point that is not Africa specific, suggests that it is higher in younger age groups compared to that observed in higher income countries, from which most of the estimates are derived. This is supported by other studies of intensive care unit and hospital admission rates in younger ages and pediatric cases. Children in sub-Saharan Africa who are hospitalized with COVID-19 are dying at a rate far greater than children in the US and Europe, according to a new multi-center study. There is, as I mentioned, a possible slight under age 5 specific mortality effect as well. There is a very good study done in Lusaka, Zambia, using post-mortem polymerase chain reaction diagnosis that observed suspected elevated COVID-19 mortality in under age 5s, making their deaths comparable to individuals aged roughly between 20 and 55. This has not been seen in higher income settings. The Zambian findings are being further investigated. And finally, to say that the US CDC, as you noted, reported that unvaccinated children from 5 to 11 years old were hospitalized with COVID at twice the rate of vaccinated children during the winter Omicron variant surge, based on data from hospitals serving 10% of the US population across 14 states. The study found that for every 100,000 unvaccinated children in the age group 19.1 per 1,000 were hospitalized with COVID-19 between mid-September and late February, compared to 9.2 per 100,000, 100,000 vaccinated kids. The study also offered some of the strongest evidence to date that racial disparities in childhood vaccination might be leaving Black children more exposed to severe illness from COVID-19. This is not a very clear slide, but from the University of Washington, the Institute for Health Metrics and Evaluation gives an indirect age standardization of excess mortality. South Africa is the only country in Africa of the 55 countries that is able to attribute death to COVID-19 directly. And so this is an estimate based on very poor data, but you can see what is the case in Africa. The second question is, what is the nature and scale of COVID-19 disruption of routine immunization programs? And first of all, to say that the disruption is on a global scale. A generally unappreciated effect of COVID-19 on children has been the global disruption of routine childhood immunization. Alarmingly, the COVID-19 pandemic threatens to undo years of progress for children's welfare. 90% of 105 countries reported some disruptions to essential health services, with routine immunization being the most frequent. In addition to routine immunization disruptions, there were 57 postponed mass vaccination campaigns in 44 countries for measles, polio, yellow fever, and other diseases affecting millions of people. 1.7 million children did not receive their third dose of the DTP containing vaccine in 2020. The WHO UNICEF estimates of national immunization coverage are the first to reflect global disruptions due to COVID-19. In 2020, 3.7 million more children globally missed out on the routine immunizations in 2019. 1.7 million children in Africa did not receive their third dose of the DTP containing vaccine in 2020. Across the board, the reduction between 2019 and 2020, the data for the WHO Africa region showed reductions in percentage coverage across the board between 2019 and 2020. Coverage for the DTP1 vaccine fell by a percentage point to 79% in 2020, for DTP3 from 74 to 72, and for MCV1 from 70 to 68. Globally, DTP1 coverage fell from 90% to 87% between 2019 and 2020, from 86 to 83 for DTP3, and from 86 to 84 for MCV1, which is far below the 90% coverage target for herd immunity. 45% of 7.7 million African children missed out on the first doses of DTP, measles, and polio vaccines. The nearly 10% rise in missed vaccinations on the previous year in Africa was driven by disruptions to health services by the COVID-19 pandemic, new data from the United Nations Children's Fund and the WHO show. Ethiopia, Nigeria, and the Democratic Republic of the Congo are among the top 10 countries to record the greatest number of unvaccinated. 8 African countries reported major measles outbreaks affecting tens of thousands of children. Between 2020 and January 2020 and April 2021, 8 African countries reported major measles outbreaks affecting tens of thousands of children, largely due to low immunization coverage or delayed vaccination campaigns. In addition, in 2020, the quality of measles surveillance in Africa fell to its lowest level in 7 years, with only 11 countries meeting their target. Preventable deaths in children under 5 were at 5.2 million worldwide in 2019, down from 12.5 million in 1990. According to a report by UNICEF, the WHO, the United Nations, and the World Bank Group, preventable deaths in children under 5 were at 5.2 million worldwide in 2019, down from 12.5 million in 1990. The same report estimates that without urgent and compelling coordinated action at an international level, COVID-19's impact on global supply chain and political priorities threaten to send childhood mortality rates back to those of the 1990s, reversing the gains, the massive gains that have been made over the last 2 decades. Let me then turn to the questions for the top reasons for health service disruptions in Africa. So this slide indicates that in the case of Eastern and Southern Africa, that the top reasons for why there has been a disruption has to do with a reduction in demand due to the fear of infection, interruption in community engagement activities, the unavailability of key supplies, and before that, the third reason is lockdown restrictions that imposed on service providers and their mobility to do with transportation, mobile services, and in both the public and in the private sector. And then finally, in terms of the top reasons, the unavailability of key supplies in both public and private pharmacies or at service delivery points. The key interventions that would be required to reverse that is to upscale community engagement, to raise greater awareness, and to introduce behavioral change strategies, a different incentive architecture to address the demand side barriers facing individuals, efforts for improving infection prevention and control, IPC for essential health service delivery, change or adaptation in venues where the vaccination sites principally, and enhancing social accountability and feedback mechanism platforms as part of the responses. These are the recommended interventions to deal with reversing the consequences of disruption in the case of Eastern and Southern Africa. In the case of Western and Central Africa, as you can see, reduction in demand due to fear again of infection, personnel gaps, lockdown restrictions on service providers, and the lack of income to pay fees. And in the case of Africa, most healthcare is paid for out of pocket. So, and so that puts a great strain on people. And so in this case, again, the key interventions required would be to upscale community engagement, behavior, and introduce a new architecture and incentive structure to change behavior, improving IPC for essential health services, again, change in vaccination sites, where there are barriers to access, and to reduce out-of-pocket expenditures or other incentive, exactly the same strategy as in the case of the other parts of Africa. So the question here, given the gravity of the situation, is what is to be done? And what is to be done is for a sustained catch-up program to be introduced as a matter of great urgency to restore services and vaccination campaigns that have been suspended or ended, so that vaccine can be safely delivered, to help health workers and community leaders communicate actively on safety issues. Generally, the technical term would be risk communication, to upscale that, and particularly with caregivers, and to explain the importance of vaccinations, to rectify gaps in immunization coverage, including identifying communities and people that have missed vaccinations during the pandemic, to ensure a more independently planned system of vaccine delivery and that can be financed and that occurs alongside and not at the cost of childhood vaccination services, and to introduce and implement country plans to prevent and respond to outbreaks of vaccine preventable diseases, and to strengthen immunization systems as part of COVID-19. So to turn to the really important question about the impact of COVID-19 on children's mental health, what do we know? COVID-19 has disrupted the lives of tens of millions of children, and there are 5 crises facing children after 2 years of the pandemic. So the first effect, of course, has been the compound impact on children's well-being, nutrition, mental health, and learning. UNICEF and partners reached out to about 7,000 households in 7 countries, covering nearly 13,000 children in North Africa and the Middle East. The WHO divides into 2 when it comes to Africa. North Africa is part of the Mediterranean zone together with the Middle East. And in that part of the world, which includes North Africa, according to the surveys, almost all families stated that their children were negatively affected. Over half of the respondents say that their children have been struggling mentally and emotionally. 40% of the respondents expressed concern about the damage that the COVID-19 crisis is having on their children. Half of the parents and caregivers thought that distance learning was ineffective due to a lack of resources, limited access to the internet, the lack of support from adult family members, and difficulties associated with teachers. And nearly 1 out of 5 respondents mentioned a financial impact that is having less money available to spend on food. 5 crises facing children after 2 years of the pandemic. First of all, a rise in violence. It has been estimated by Save the Children that that since the start of the pandemic, an estimated 10% more children have been forced into poverty. Mental health helplines have seen a demand surge by as much as 7,000%. And about 2.8% of the world's children remain out of school. And children globally have reported a rise in both domestic as well as online abuse. 25,000 people were surveyed across 37 countries, including those in East, Central, West, and Southern Africa. The rise in violence, children reported higher rates of violence when schools were closed compared to when attending class in person. It is also revealed that 1 in 5 caregivers reported an increase in their use of negative or violent parenting methods. The latest figures from South Africa show that more than 350 children were killed in the last 3 months of 2021. And there was a 30% jump in attempted murders, with most of the violence taking place at home. Worsening mental health, children have been overwhelmingly affected by negative feelings as a result of the pandemic and a disruption to their lives, including from the lack of socializing and school closures, with uncertainty and stress contributing staggering levels of loneliness, anxiety, and depression. In India, to speak about India, calls to the helpline spiked when the country faced record record-breaking cases of COVID-19 in spring 2021, with a 7,000% increase in calls from March to April. These are online helpline calls. Governments did not adequately respond to the huge increase in children's mental health and well-being needs. Mental health programs represented only 0.54% of the $3 billion allocated to the UN Global Appeal Fund. There's a rise in online violence. Lockdown measures led to more children relying on technology to learn and staying in touch with friends and family. However, not all children had the knowledge or the resources to stay safely online, putting them at risk of exploitation and online abuse and leading to worrying mental health effects. Online abuse, harassment, and bullying might have had as many negative consequences as physical violations and abuse. With schools being closed, the COVID-19 pandemic caused the biggest education crisis in history, with an entire generation of students unable to go to school, more than 1.6 billion children at its peak. School closures are currently affecting 43.5 million learners in 6 countries, or 2.8% of the world's total student population. This is in Africa. Prolonged school closures have worsened inequalities. They have badly affected children who lack access to technology and other support for home learning, resulting in learning losses and increased dropout rates. And then finally, if that's not enough, there's been a surge in poverty. According to the UNICEF and Save the Children, since the onset of the pandemic, an estimated 100 million additional children have been driven into poverty. This is a worldwide figure, which is a 10% increase compared to pre-COVID-19 levels. This spike means that a projected 1.1 billion children are now living in poverty. Families in lower income countries have been hit the hardest and are recovering at a slower pace with higher levels of unemployment. What is to be done? Repurposing and repackaging mental health and psychosocial support to address the impacts of COVID-19 pandemic, the continuity of learning for all children and safety in schools, including through bridging the digital gap and exploring low-cost technologies, implementing a jumpstart package to equitably address access to primary healthcare children and mothers, scaling up and adapting infant and young children feeding programs and public messaging, expanding social protection systems to reach the most affected children and their families, including through expanding cash transfer programs, promoting government budget and allocations and public financing in social sectors with a specific focus on healthcare and children. Just very quickly to note, let me just also do a time check, that COVID-19 has an impact on the health workforce, including the pediatric workforce. It's the most severe shortage in the world. Only 14% of healthcare workers have proper access to PPE. The percentage of healthcare workers never feeling depressed has been down by half. 50% of healthcare workers reported safety concerns regarding COVID-19. And finally, the COVID-19 impact on health systems is to say that we all, the globe, we've been inadequately prepared for the pandemic. To start off with, when the health system is supposed to surge during catastrophes, never mind about that. The basic services, in the case of hospitals in Africa dealing with children or centers, they're not even able to maintain those basic services. Before COVID-19, Dr. Larry Stanbury and Dr. Philip LaRussa and I launched a project in Africa to assess the surge capacity of centers dealing with children. The project was called CHAMP, funded by the Alma Foundation, and later also by a emeritus professor of political science, Charles Hamilton. where we identified gaps in staffing, in laboratory ancillary services, in the medical records department, and in quality assurance and improvement. And specifically, we determined that there was little of a disaster response program in place, that there was funding for disasters set aside on paper, but very difficult to access, that there was not enough staff, inadequate number of trained professionals at all levels. When it comes to medical supplies, 68% did not have medical supplies to meet current pediatric needs. 32% reused disposable medical supplies. When it came to competency-based training programs, 53% had a formal training for the use of PPE. 79% had formal IPC programs. When it came to medical disposal, 80% had formal SUP for waste disposal. 20% had formal HEAI programs. In terms of electricity supply, 84% experienced blackouts, some frequently, but 100% had emergency generators. When it came to water supply, 58% experienced interruptions in their water supply. So just to note that this was a measure of pre-COVID capacity to deliver services in the case of both independent children's hospitals. There are only 5 freestanding children's hospitals in Africa. So we looked at those hospitals, but also at pediatric wards in general hospitals covering a range of countries. And none of them had the capacity to surge during a catastrophe. And in fact, they did not have the capacity to deal with routine matters when it came to services provided to children. What is to be done in the short term? The most important priority is to support the professional staff in terms of training opportunities and financial incentives to help them remain in country. And secondly, to help facilitate more robust networks of hospitals that could develop multi-center interventions to address the challenges. I was going to talk about what it meant to vaccinate in countries where there's a war that's ongoing. It's one thing to deal with the difficulties of vaccinating in settings that are in countries that are at peace. It's quite another matter to deal with Yemen, to deal with Syria, and to deal with all these countries in Africa. They're formidable barriers, but I don't have time to get into that. Let me just end by saying that, just a review of where we are with COVID vaccinations in Africa. The Our World in Data Vaccine Tracker reported that as of April the 10th, a total of 465 million vaccine doses have been administered across the entire African continent. 15.3% of the population has received more than 1 dose. 5.14 given at least 1 dose. This brings the total number of Africans that are vaccinated to 20%, 20.51% to be precise, share of people vaccinated against COVID-19. According to Our World in Data Vaccine Tracker, as of April the 3rd, 2022, the 3 best countries by share of people vaccinated are the Seychelles at 85%, an island, Mauritius 79%, again an island, Morocco at 67%. The 3 lowest are Burundi, 0.084%, the Democratic Republic of the Congo at 0.92%, and Chad at 1.7%. Currently, the Omicron subvariant BA.2 has become the dominant form of SARS-CoV-2. It is very closely related to the original BA.1 variant, but the BA.2 subvariant is between 30% and 50% more contagious. A new assessment of virus seroprevalence suggests that nearly 3/4 of Africans have already been infected with SARS-CoV-2 prior to the onset of the Omicron wave. The analysis, a systematic review of some 151 countries, was published in medRx 4.org. Addressing a press briefing on Thursday, this past Thursday, the WHO Africa Director, Dr. Moeti, said the study demonstrates that there had been some 800 million infections as of September 2021, nearly 100 times greater than the 8.2 cases reported at the time, 100 times greater. The data does not even consider the Omicron wave of infections that hit countries in Southern Africa in early December and continued into nearly 2022. Finally, it is now worth reconsidering, therefore, the WHO Africa CDC target of vaccinating 70% of the population, when that threshold has already been exceeded with infection-induced immunity. And this has held up as well, and perhaps even better than vaccines, including mRNA vaccines, in preventing mild and severe COVID-19 effects. The most efficient use of the current generation of vaccines, therefore, which do not fully and sustainably protect against infection and mild disease, is to target getting the over 50-year-old population vaccinated, at least to a level at 90%. This age-bound target will be less than 20% of the population, but yield more benefit than vaccinating a random 70% of the population. Vaccinating children in Africa, therefore, is not on the cards. And with that, I thank you, and I think I've gone over my time with apologies.
Wilmot, thank you so much. That was just a terrific talk. I think it's really critical that we understand that delivery of vaccines and focusing on healthcare delivery systems is just as important as understanding the basic biology of the viruses and their spread in vitro. I'm sure there are questions. I have one quick question, which is, I know you've been very involved in education. Could you tell us a little bit about how you would change medical school education so that people appreciate these issues with vaccine delivery?
Well, the issues with vaccine delivery is one part of a chain of events that have to occur, especially during a pandemic. We need to understand how vaccines are produced, how they are manufactured. And prior to that, of course, there's the basic science that precedes that. We need to understand how vaccines are distributed and what the mechanisms are. We've learned with COVID-19 that even the most inventive mechanisms, which is COVAX, in order to regulate distribution to the developing world, has had limited effect and in fact failed in many respects. But the actual logistics and the mechanics and the economics of delivery is something that needs to be understood. And then the really important question is how to deliver those vaccines to where they are needed rather than those who can afford it. So in order to deal with the challenges of the pandemic and not other issues. And that is no good having vaccines sitting in warehouses and airports. They have to get into people's arms, which raises the issue of vaccine platform delivery systems. Most of those are designed for children, as we know, importantly. And in case of COVID-19 and in the case of Ebola, those have to be redesigned for adults, which is a different story altogether. And then finally, the question of vaccine take-up. Under what circumstances do people feel confident in accepting vaccines? And we can see what the challenges are presently. So that whole chain ought to be introduced within medical education for it to be understood beyond the public health and clinical aspects that you normally, of course, deal with. And that involves other disciplines, say social science disciplines, in economics, in engineering when it comes to delivery systems.
Thank you. We have a question from Sten Vermund, probably from Yale. Professor James, can you go into more detail as to the progress of licensing innovative mRNA products to African-based manufacturers with a goal of meeting continental demand at a more affordable cost?
So a fundamentally important question. So I work with a team of 20 experts called VacTask, chaired by Jeremy Farrar, the Wellcome Trust, and I'm the deputy chair, and we work with individuals from the Gates Foundation, from CEPI, and elsewhere. and from industry. And we are advising African governments on the introduction of vaccines on the continent. mRNA vaccines are great. They're a wonderful platform. And everybody is sort of mesmerized by that too. But we must not forget that, vaccines using other methods are also very important. And in many cases, given the logistical issues around refrigeration, it's important to develop a portfolio of vaccines that can be used for pandemic response, but at the same time for routine vaccinations. And getting that right is very difficult. And this has to be sustainable. Right now, there is no demand for new vaccines in Africa. They're returning the vaccines because of a lack of take-up. So you can't create a facility to produce vaccines and then mothball it. So sustainable vaccine manufacturing is a tough thing to get right. And we are trying to help. There are 7 countries in Africa presently who are either in the process of setting up facilities or would like to set up facilities. So we're advising them to look at sustainable vaccine production in time for when the next pandemic comes. So it's not going to help the current pandemic, but to prime ourselves to be able to do that. But the general principle of dispersed vaccine manufacturing across the globe so that we don't face a repeat of what we've seen in the past is an important thing, but we have to get the business model right to do that.
Great. Other questions? I have a question that I would love to know the answer to, but I'm not sure the data are available yet. I'm curious to know both in Africa and in this country, what rates of childhood diseases that would normally be covered by the vaccines, how are those rates increasing? Like, are we now seeing more measles deaths? Are we seeing more pertussis, more invasive pneumococcal disease? Do we know that?
No, we don't know that. I mean, there are some episodic reports indicating that. And there are also a number of studies in a small number of settings indicating that, but we don't actually have a grip on what the overall effect is. There's a warning that there would be an increased series of measles outbreaks, for example, but putting numbers on that at this time is not possible.
And one other question, I'm dominating the questions, I'm afraid, is what about polio vaccination? So there have been a couple of isolated reports about wild type or vaccine-associated polio. Has that also increased with this gap in normal childhood vaccinations?
Yes, as far as we can tell, it has.
I have another question from Dr. Vermont. I have a question from George Lazarus, who was my chief resident here back in the days of the Giants. George is asking, are centers giving vaccines to all age groups so that the older population over 50 coming for COVID vaccination might bring their children and grandchildren for routine vaccinations at the same time?
So we presently have a study, ongoing study in South Africa and Zimbabwe, looking at individuals who present themselves for vaccination for COVID-19, and we conduct interviews to assess which obstacles they faced, who influenced them on a localized basis. And so, and what happens is that many of the people turn up with their families, and they go to a great expense to do that. They cross many barriers, but the vaccination facilities are not equipped to deal with. They have an age grading system in place, and you can't turn people away, especially when they do that. So that's one great difficulty that African countries are facing in terms of being able to deal with COVID-19 vaccines, but also with routine vaccines. So that's one answer to that particular question when it comes to vaccination sites for COVID-19. For routine vaccinations at clinics, the greatest impact of vaccine hesitancy around COVID-19 is on mothers are really worried now and questioning the safety of your traditional vaccines as well. So as I noted, there's a drop-off in that case, and we're picking that up as well.
Another question is, do we know the current status of the COVID-19 pandemic in South Africa, which I believe is the most heavily affected nation in Africa, possibly related to crowded conditions, high mobility of the population, and temperate zone environments?
So South Africa is driving the growth of infection rates with the current wave, the fifth wave. So South Africa is making the greatest contribution to that. And more than most countries in Africa, South Africa is highly urbanized, with a significant portion of the population living in informal settlements. That together with the fact that people have just relaxed doing normal things like masking. And there are no mask mandates of significance in place, except for some schools and some private entities. People are tired of COVID-19. There's a sense that the pandemic is over, and it's not over. And those things all add up to the current drive. But as I noted, the comment from one of South Africa's most distinguished vaccine experts, Dr. Shabir Mahdi, is that the naturally induced immunity from past exposure to COVID-19, together with the current low vaccination, nevertheless is resulting in a low level of mortality, and so that the symptoms are relatively mild.
Great. Well, thank you very much. That was really incredibly informative, and it's striking how the United States has exactly the same issues, both with routine vaccinations and with vaccine hesitancy, that we still have yet to learn how to deal with effectively. But I think I will have everyone join me in thanking you for a terrific lecture, and we really appreciate your expertise and your insights into this problem. And I think I'll turn it back over to John Babineau, who's going to host the rest of the program. Thank you again.
No, with pleasure, and thank you to everybody for listening.
Thank you, Professor James, and thank you, Alice. It was a very eye-opening discussion, and I appreciate the questions from the group as well. This is, as I mentioned, 47th Hattie Alexander Memorial Lecture, and this certainly has been quite a time when it comes to infectious disease and how that really interfaces with all of our health systems challenges, as Alice, you just pointed out, both here locally in the United States and certainly around the world. So thank you for this very pertinent lecture this morning, Dr. James.